my name is Sarah, and I'm a medical student from Baghdad, Iraq, from the University of Baghdad College of Medicine, and I'm highly interested in plastic surgery. Today, I will talk about scalp flaps from plastic surgery perspective. Now, screen sharing. Yeah. Yeah,
Perfect.
scalp flaps.
Perfect.
Now, yeah, today we talk about scalp flaps from plastic surgery perspective. Let's start. My presentation will divide into two parts. In the first part, I will talk about flaps and the classification of flaps in general. The second part will talk about a reconstruction of scalp by flaps and discuss the most accurate flaps options in each region according to the defect size of that region. Let's start with the first flaps. What is a flap? A flap is a unit of tissue that maintains its own blood supply while being transferred from its donor side to the recipient side. For example, here we have a jury flap. The donor side for that flap is the temporoparieto-occipital regions. The arteries included in it, it's the posterior branch of superficial temporal artery and the occipital artery, while the recipient side for it is the anterior hairline, so that the flaps here used to reconstruct the anterior hairline and to correction some male pattern of baldness. Now, the flaps are classified according to three important principles. It's vascularity, tissue composition, and method of movement. According to vascularity, there is five important types of flaps. It's random, axial, island, perforator, and neurocutaneous flaps. Tissue composition also have four important flaps types. It's the facial and faciocutaneous flap, muscle and myocutaneous flap, visceral flap, and composite flaps. While the method of movement divided into three types of flaps. The first one is the local flap that divide into advancement flap, rotation flap, transposition flap. The second type is the regional flap, and the last one is the free flap. Now, the second part of the presentation is scalp reconstruction by flaps. Start with the goals: tension-free closure of defects, maintenance of motor and sensory function when possible, maintenance of contouring, and a protection of the cranium, dura, and the brain. So the question here is, how do I choose the right one? I mean flaps, and does it differ with different location? To answer these two questions, we'll classify the scalp flaps according to location and defect size. In location, there is four important regions. It's the anterior or frontal region, parietal region, vertex region, and the occipital region. The defect size divided into small, moderate, and large one. Now, a quick review for the scalp regions. Start with the frontal region, as we saw here with the green color, and this patient with the moderate frontal defect. The second one is the parietal region that included with the temporal region, as we saw here. And the third one is the vertex region. The last one is the occipital region, the patient with a large occipital defect. Now, flaps options. There are many flaps options. For that reason, we'll talk about the most accurate flaps options in each region according to the defect size in that region and some important principles that must take into consideration when dealing with that flaps in the specific regions. So we'll start with the first region. It's the frontal region. For the a small defect, we have three options. It's the primary closure after undermining the surrounding tissue, advancement flap, in that case used to lowering the anterior hairline, and the third option is the small rotation flap. For the moderate defect, can reconstruct it with the VY flaps technique. It's a subcutaneous bipedical rotation advancement flap. The second option here is the temporoparieto-occipital flaps, as we mentioned above, that it's used to reconstruct the anterior hairline and correction some pattern of baldness. For the large defect, can reconstruct with the temporoparieto-occipital flaps and the large rotation advancement flap. For that flaps, we need for the incision usually need to be 4 to 6 times of the defect, and we need for the skin grafting to the donor side. The third option is the tissue expansion technique, tissue that's used when the defect size is as much as 50%. A highly aesthetic result can be obtained by this technique, but it's not preferred in many patients because it's two-stage procedure. Now, to reconstruct that large frontal defect, we use something that called a large bipedical flaps. And that flaps need to included the arteries from two opposing sides. So the arteries included in it, it's the superficial temporal artery from each side, and the pattern of movement here, it's called packed handle movement, and we need for skin grafting to the donor side. Now, the surgical piers, it's very important to preserve the anterior hairline and pro-symmetry when dealing with the frontal flaps. Now, the second region, parietal region, start with the small defect. The options of flaps, it's primary closure, rotation flap, VY flaps, and rhomboid flap. Rhomboid flap used for temporal sideburn reconstruction. Now, for the moderate defect, the flaps option is rotation advancement flaps, pile loop flaps, and also can use as shape flap. For the large defect, the options is tissue expansion. It's two-stage procedure. The second option is large bipedical fronto-occipital flaps, and that flaps also you need to require to include the arteries from two opposing sides. So the artery that included from the posterior or occipital region is the occipital artery, and the artery included from the frontal region is the supraorbital or supratrochlear artery, and we need for skin grafting to the donor side. Now, the surgical piers. This region is highly, it's characterized by highly scalp mobility, so it's amenable to local tissue rearrangement, and it's important to avoid the sideburn displacement from aesthetically perspective. Now, small quiz. What is the flap option for the defect? You can take your times to think about the appropriate answer. So, yeah, the right answer is the rotation advancement flap, as we saw here in that picture. Now, the occipital region, the third region is the occipital region. It starts with the small defect that it's easily reconstructed by the primary closure after undermining the surrounding tissue. For the moderate defect that can reconstruct with the rotation advancement flaps, and the arteries included in it, it's the occipital artery. For the large defect, can reconstruct with the large rotations flaps that called artichokia flaps, the name of the Mengele artichokia, the professor of plastic surgery. That's a flap is a three flap technique that improves the vascularity compared with the four flap technique. So it's classically described to reconstruct the large occipital defect. Now the surgical periods. The occipital region is a moderate scalp characterized by moderate scalp mobility, so it's amenable for the local tissue transfer, and it's important to preserve the occipital hairline. Now, the last region, the vertex region, starts with the small defect. The options is a primary closure, pinwheel flap, and the rhomboid flap. For the moderate defect, can reconstruct with the pinwheel and rhomboid flaps, double opposing rotation advancement flap, or S-shaped flap, that used to reconstruct the circular, moderate circular scalp defect for more than one region. The third option is rotation advancement from the occiput. For the large defect, we can reconstruct it with the large rotation flaps. In that flaps, we need for almost completely scalp undermining, galley scoring, and also need for skin grafting to the donor site. The second option is the tissue expansion, and best aesthetically result can be obtained. Now, the near total defect, when the defect is more than 50%, can reconstruct it with a free tissue transfer. The most used tissue is the latissimus dorsi muscle, rectus abdominis muscle, and the anterolateral thigh. The second option is the serial tissue expansion, and the third one is dermal regeneration template. It's a type of a biomaterial that's used to reconstruct it. It's composed of collagen lats that covered with a thin silastic sheet. Now, the other small quiz. What is the flap option for defect? Also, you can take your time to think about the appropriate answer. Yeah, the answer is S-shaped flaps, as we saw here in that picture. Now, a summary. As a summary for flaps according to the location and defect size. For a small scalp defect for all regions, primary closure is the first options. For the moderate scalp defect, if it's a frontal region, we can use VUI flaps and temporoparietal flaps. If it's other regions, the rotation advancement flap is the best choice. For the large scalp defect, there are different options of flaps according to the region. So if it's a frontal region, the flaps option is temporoparieto-orbital, occipital flaps, rotation advancement, and tissue expansion. If it's parietal region, the option is tissue expansion, bipedical fronto-occipital flaps, while the rotation flap is the best choice for the occipital region, and in the vertex region, the flaps option is rotation and tissue expansion. Now it's important to take into your consideration that use adjacent scalp for reconstruction if possible, and incorporate at least one main named scalp vessel in the flaps. The reference for more information. And lastly, thank you, and thank you for your times.
Okay, very good. Samar, are you online?
Hi,
Yep.
John.
Go ahead.
Do you hear me?
Go ahead. Go ahead, Samar.
Okay. Hi.
Okay. I guess we're continuing to have problems. But Sarah,
Yes,
okay,
there
go
is
ahead.
some.
Go ahead, Summer.
Actually, I want to thank you for giving this opportunity to our medical student, and I would thank Fatma and Sarah for this uh, rapid overview about these topics. And these two presentations are part of our new project combining the experience of neurosurgery and plastic surgery regarding scalp anatomy and scalp surgery. That's our idea, and I think within a few days, both of these students will present another presentation, but in an advanced level about scalp flap from different perspectives.
Excellent. Do you want to take questions, Summer?
Yes, we are ready to have a few questions, and if it's for me or Fatima or Sarah,
Okay,
that would be nice.
yeah, I just have a question. Samar, as a general neurosurgeon, I guess you must have to do a lot of your own plastic work, right? Or do you kind of have to learn it on the go on the fly? Or do you consult a plastic surgeon every time you need an extensive revision or whatever?
It's according to the lesion
Okay.
and according to situation in general. If there is scalp defects, large scalp defects, we want to consult the plastic surgery and ask about your opinion and further management. But what we are trying to do here is
Yeah, I'll just finish his what I think his thought is. Trying
yes,
to establish. Go ahead, Samar.
yes, and what we are trying here is to uh, find the principle that this plastic surgery use while dealing with with the scalp in general and different flaps and vascularity, nerve supply, and also we are trying to apply these general rules from the plastic surgery perspective on our specific flaps. This may made new flaps or may made better apprehension of our already used flaps.
Hmm. Okay. Harshad, do you have any questions or comments for either Samar or Sarah and Fatima?
It's an excellent presentation, John. Sarah has presented very well and very nice. And I'll tell you one thing: we are doing all this head injuries since many years, and every time we always involve plastic surgeon. They are the better people to help us out rather than we doing free flaps and all. Whenever you can do a rotation flap, but there is a defect which remains there, and for that we need a graft to be taken, whether we need a vascular graft, pedicle graft, or a free graft. And I personally feel we should involve plastic surgeons who are better than us to reconstruct the scalp. Skull, yes, we are very good in reconstructing. We have got a lot of materials nowadays available right from your own patient's own skull to various materials and the metallic materials. But for a scalp, I would always take help of a good plastic reconstructive surgeon.
Okay. Thank you.
Nice presentation, John. Good.
Thank you.
Okay. Thank you.
I,
Thank you
I
so much.
agree.
Okay, Samar.
I agree with the Dr. Harshad opinion. It's exactly combining idea and doing a teamwork is the better to find solution. And what we are doing now is uh, we're trying to revise the topic at the basic level. That's the idea.
Do you do you foresee
Excellent.
do you foresee a subspecialty in this area of plastic neurosurgery, a fellowship or whatever, or no? You don't foresee that.
Uh, hmm. I don't know exactly. Maybe there is something similar somewhere or another, but
Okay.
in a specific, uh, actually, even while we are reviewing the topic, we don't find the principle of scalp flap from this perspective, even as a chapter in our books. It's always a general one, not a specific.
Right.
I think that's give us the idea. What let's over give an overview of the topic. Let's combine the already known facts that Sarah and Fatima presents. They are already known facts. What we are doing to make a summary and overview, and let's find a few direction, hopefully in the future.
Okay. Excellent. Excellent. So next week there's similar presentations.
We hope so. It depends, and we are already preparing something, but we'll contact you for the exact time.
Okay. Okay. Very good. Okay.
Okay.
Sarah, any parting words or Fatima?
I just
Oh,
want to say that thank you for everyone that saw me, and thank you for you, Sir John.
Yeah. Thanks for the time. That was a great presentation. How Fatima?
thank you, John. Thank you for time, and thank you, Ami, for this. Thank you, Dr. House, for this opportunity.
Okay, you both did a great
Mm,
job. Great job.
Thank you.
Okay.
Hey, John,
Yes.
Dr. Saleh here. Can
Well,
I share
excellent.
one?
Yeah. Hi, Dr.
Yeah,
Saleh.
yeah. Hi, how are you? Yeah.
Welcome.
Actually, I'm Dr. Saleh from Bangladesh. So this is one of my patient, this young patient. Can you see the
Yeah. You don't mind,
picture?
Samar, right? That's
Yes,
fine. Go
yes,
ahead.
sure.
Go ahead.
Yeah, yeah. So this 30 plus years old gentleman who had some parapulsion meningioma initially operated within few months, the thing recurred, and he underwent 3 consecutive surgery. At last, I got the patient on the 4th time. When I found him, he is having the recurrence of intracranial as well as you see the scalp lesions. So I took my plastic surgeon colleague regarding the scalp management because he has skull as well as scalp deficit after the surgery. Unfortunately, 1.5 months of the surgery, we did the surgery, removed the tumor. It came as anaplastic meningioma, atypical meningioma grade 3. So again, the repeat scan shows I couldn't share it. There is some recurrence in the scalp, small nodule-like lesion. So this is a big challenge. I talked with the radiation oncologist colleague that how can they can help us, whether they will go for the oncological management or will go again. So this type of scalp problem, what do you think, your experience regarding removing this lesion and reconstruction, this scalp?
Go ahead,
Mm,
Samar.
I don't see the whole case, but
Oh, okay.
I get an idea about how difficult it is. And the answer I don't know, because I think yes, it require a team discussion about the clinical stage of the patient and the possibilities available. And that's why I don't think that
Patient is neurologically intact.
I know, I know. No, it's about the what's the patient let's say demographics and current status and expectation. That's the idea because you are uh, dealing with patient expectations. And I think if you send me the case in a
Yes.
private, yes,
Yes.
I will make it more professional opinion and send back to you.
Okay. Okay.
Okay,
That will be good option.
Or do you want
it's my pleasure.
to? Okay.
Thank you very much.
Thank you.
Thanks, John.
Yeah. If you want to leave your email in the chat, what's the best way to hook you guys up? Do you have each other's email, Samar?
I
No,
can
I
share.
will post my email.
Okay. Samar's going to post it. You can see the chat, right?
Yes.
Okay. Just post it in the chat there, Samar. I think he'll get it.
Okay.
I just posted it directly to my my
Oh,
email.
there you go. I see Samar. You see Samar's?
Yeah, I could see.
Okay.
Thank you.
Okay.
Okay, with a pleasure. Thank you.
Okay.
Okay. Very
Nice
good.
to meet you.
Okay. Anyone else have something to contribute? That was excellent, Dr. Select. That's great to do that, to spread learning like this. Anybody else? Go
I
ahead.
think we can give it as an example. The next presentation also, the final product of our discussion with Dr. Salik, we may put it as an example in the next presentation. That
Oh,
will be good
Yeah.
as feedback. Yes.
that would be great. Does that sound
Yeah.
good, Dr. Select?
Yes. I think I will prepare the case as per the requirement, and we'll project this one as a case, problem-based case next session. That's
Okay.
fine.
That's nice.
Okay, excellent.
Thank you.
Okay, everyone, thank you very much, Samer, and to both presenters. And we're going to see you next week. We'll let you know the program when Samer has it put together. So thank you very much, and we'll see you next week.